Glenn. I appreciate that. Folks will all get a pop-up to just go ahead and authorize that. Well, let's go ahead and get going with our agenda for the afternoon and some introductions. Let me just welcome all of you. Again, my name's Janice Tondora. I'll tell you a little bit about my background, as will my co-facilitator today, Dan Mortenberg, in a minute. But you are here for our MHTTC webinar, specifically around designing electronic health record planning templates to support the practice of person-centered recovery planning. And Dan and I are really excited about this one, actually. I'll tell you a little bit more about the series in a minute, but this is the fourth of a series of 6 webinars around supporting the implementation of person-centered recovery planning. And to date, we've focused more on kind of the clinical and the partnering skills that go into quality PCRP. But we also recognize that the tools that people are given to capture their person-centered planning processes can really honestly make or break the quality of that planning document that comes out of it. So Dan and I have done quite a bit of work in this space, and hopefully you're going to find this presentation pretty practical this afternoon. So let me just do some basic, our standard disclaimers. So this webinar in the series is funded under a cooperative agreement with the Substance Abuse Mental Health Services Administration, also known as SAMHSA. While this topic today in this series on person-centered planning, we believe it to be in alignment with the SAMHSA mission and the strategic plan, the content and the opinions that Dan and I express today are really expressly ours and not representing an official position of SAMHSA or DHHS. And if you're not familiar with the MHTTC, that stands for Mental Health Technology Transfer Center. In this webinar series on person-centered recovery planning, there are 10 regional centers around the country. This webinar series happens to be co-sponsored by Region 1, which is New England, and Region 6 in the dark purple down there, the Southwest MHTTC. And our mission at the MHTTC, we support workforce development around the uptake of both evidence-based and other innovative practices around the country. And in Region 1 and in Region 6, we have a particular focus and an interest on the uptake of what we call recovery-oriented or person-centered practices. So obviously our topic for today is in keeping with that. And we always like to share the basic language principles that were developed collectively by the network in terms of consistently using affirming, respectful, and recovery-oriented language. And of course, we're going to continue to try to do that today throughout our event. And then just a few housekeeping items. We have never had to my knowledge, close down a virtual webinar because of unwanted guests or disruptions. But if we ever had to do that, there would be email follow-up. We are expecting a little bit of a bigger audience, but we may end up being small and mighty. So that's all the more reason Dan and I hope that this will be a bit interactive this afternoon. You do have the ability to unmute. You could raise your hand feature. We also hope that you will make very active use of the chat. Dan and I also put a couple of polls into the session this afternoon. In terms of questions that you have, first of all, we encourage you to ask them and to put them in chat. And when you put them in chat, please direct them to everyone, just because that's going to make it easier for us to track them. Dan and I are pretty informal in our style as presenters, and we may kind of pause in the moment. I may say, hey, Dan, can you jump in and say a little bit more about this? But we will also try to leave a few minutes at the end for some Q&A. And then after this event, from the Southwest email address, you will get an email that has a link to download your CEU certificate that you can then use to work with your various licensing and credentialing boards and whatnot. But just please note that participation in the full duration of the event, the webinar today, is required in order to get that CEU. So that was a little bit of our housekeeping and disclaimers. Let us tell you a little bit about who we are before we get a sense of the poll of who is in the room today. So, as I said, I'm Janice Tandora, and I am an associate professor at a place called the Yale Program for Recovery and Community Health, which is at the Department of Psychiatry at the university. I'm a clinical psychologist by training. You can read a little bit there about my work. But basically, I have for the past 20 years really dedicated myself trying to sort of move the principles and the values and the philosophy of what it means to be recovery-oriented and person-centered from the conceptual to the practical. So people have sometimes called me the nuts and bolts person-centered lady. And I've taken that as a compliment over the years because I do think people are really hungry for tools, because a lot of times the philosophy of recovery and person-centeredness, it lives in our hearts and even in our relationships, but people really, really struggle to then manifest that in the plans that they're co-creating with people. So I've done a lot of training and consultation, many states around the country. I happen to be coming to you from North Carolina. I'm from Connecticut, but I'm down in North Carolina training. We've written a couple of books on this topic, a bunch of articles, and I've done quite a bit of that work in partnership with Dan, who's going to say hello here in a minute. But also, I'm very passionate about this topic because I am a mom of a young adult who's had some pretty significant mental health issues, and we've had a lot of experiences interfacing with treatment systems. And I have seen the power of really good person-centered planning, and also seen the harm that can be done when care is not so person-centered. So I bring both a professional and a personal passion to this topic. And I'm going to turn it over to Dan to say hello.
Thanks, Janice. Good afternoon, everybody. I'm Dan Wartenberg. I'm also a psychologist by training. And I met Janice about 20 years ago, about when she was just setting out on this. And at the time, I was a clinical director of an outpatient mental health clinic in Stanford, and was just taken, how you sometimes hear something that just resonates and rings the bell about how you think the work should be done. And that really happened for me. And since that time, we've worked together a lot, and I've worked both in my own practice. I'm still a practicing psychologist, but more often in agencies to try to bring this to life, because newsflash, agencies are not really set up to make change, and there are forces at work that don't necessarily support an easy implementation of person-centered care. And in my various roles, I was a quality director for a long time. I ran an inpatient unit, an outpatient unit, was the CEO of a state-operated mental health center, and all along the way sort of found ways to try to bring this to life. And one of the, what we're going to talk about today is one aspect of that. So one of the things, we'll talk a lot more about is, I'm sure, when we started out there, electronic health records were not required. So there was a process of bringing them on board. And as they came up, everybody's, wow, this is great. It's wonderful. It's going to save us all this time, make everything more efficient. But it also, it's a lot easier to change a form than to change an electronic health record. And we had a lot of experience about, how do we make this fit? How do we make this consistent? So that's a lot what we're going to talk about today. So Janice is going to sort of set the stage, and then I'm going to just kind of walk you through. We had an experience of doing that together, and I'm going to walk you through that and go from there.
Perfect. So that's a little bit about us. And now we want to get a sense of who you are and kind of the hats that you're wearing in today's conversation. You may be wearing multiple hats, but if you could just do a quick response to our poll here, that'll give us a sense of who we have in the virtual room with us. Maybe just a couple more seconds here. All right, let me go ahead and share our results. You all see that? You good? All right. We were talking while you all were in the reading room, and sort of as anticipated, given our topic today, we've got a really robust group of leadership and administrators who are often making some of these decisions around EHR and trying to support their implementation. And I saw we've got some of our IT specialists, so that's terrific. And a good mix also, people just coming from direct support roles, bringing their own lived experience as well. So excellent. This is very helpful for us just to get a sense of who's in the room. So like Dan said, let me just make some introductory remarks and kind of frame the problem before Dan walks you through the process, and I'm going to come back in at the end and actually sort of share an example of what it might look like. So this is just a definition that we have been using around person-centered recovery planning, especially if you have not joined one of our previous webinars, but it's obviously a much more collaborative process between a person and not just their behavioral health providers, but who they might choose from their natural support network to involve in that process. And that process should lead to the co-creation and the development of an action plan that oftentimes can and should look very different from our traditional treatment plans in terms of helping the person use the plan in a meaningful way, kind of to pursue their own unique recovery goals. And this is, again, if you're joining us for the first time, this is part 4 of a 6-part series. We're doing one every month. If you would like to check out any of our previous webinars, they are all recorded and the slide decks are available and they are on our website. And we have 2 more left after today. Next week, we're tackling the topic of person-centered advanced crisis planning. And then we're wrapping things up in August, really focusing on sustainability in our implementation strategies. So talking a lot about training, supervision, quality improvement, leadership, and whatnot. So please feel free to kind of check out previous and future webinars. Hopefully we'll see you back again. So is a person-centered approach at the level of service delivery enough? I think that quote in the middle there speaks volumes, right? When you pit a good person against a bad system, the system always wins, right? So this just really speaks to the importance of the fact that we can't just be talking about developing individual staff competency. We also have to be talking about how do we align our systems, in support of the kinds of practices that we're hoping to see. Because even the most talented, committed, and skilled practitioner, if they're swimming upstream, right, against a system where policies, procedures, infrastructure, and the electronic health record are not aligned, it's going to make their job that much more difficult. So it's really important to also be thinking about systems change. And, in order for this to really work and be transformational change, everyone has to play a role in it, from the administrative support staff who greet somebody at the front door, to your plant operations staff who maintain clean, welcoming, respectful environments, to, quality monitoring, and are we really measuring the things and the kinds of practices that we're trying to encourage? And then, of course, last but not least, our leadership and administrators who are helping design the tools that we get into people's hands, and our IT specialists who are, again, modifying, helping to truly try to give people user-friendly tools that support this kind of practice. And then I just want to make sure you're all aware of a resource. That importance of those multi-level systems interventions to support person-centered planning was really echoed in the focus of an issue brief that SAMHSA put out just a couple of months ago. There's going to be a live link in the slides when you get them. And this really talks about the importance of that system alignment. It's organized around the 8 systems dimensions of person-centeredness as articulated by the National Center for the Advancement of Person-Centered Practices and Systems. That's a mouthful, but basically we're talking about systems level alignment, everything from financing to eligibility and access, culture, messaging, staff development, you name it. And I had the opportunity, I actually was able to lead the development of this brief. And so I can tell you the folks that I worked with, we worked very hard to pack it full of as many resources and tools as we could so that it would be a practical resource. So this has actually been sent to all the state mental health authorities around the country. And if you haven't seen it, I encourage you to check it out because it really is a really nice resource, has a lot of embedded tips and tools. So one quote that we put into that report speaks exactly to our topic today and the transformational change that Dan's going to tell you a little bit more about, because training and workforce development, really only get you so far, because, you can have really talented, committed practitioners, somebody who believes, a person's got a right to a person-centered plan. They're committed to partnering in its development. They've got the skills to do it, but then they're handed a treatment planning template or an electronic health record that really is designed more to support payment and systems bureaucracies than it is to support directly the person's unique recovery goals. And so sometimes the tools that we give people actually undermine the practices that we're trying to encourage. I really, I have seen implementation efforts honestly stall tremendously because of the implementation of an EHR that's not aligned. I have seen years of progress lost in systems of care where I've done a lot of workforce development, and then a new EHR comes to town and years of progress lost as people try to adapt to that. But because we're trying to be strengths-based here and optimists, I can also tell you, I have seen the design of a good, well-designed, person-centered EHR significantly accelerate adoption of this practice. And that's everything that Dan's going to tell you about in a minute. This is fundamentally the issue that we're trying to address. It's like the square peg in the round hole dilemma, right? People get really frustrated with traditional EHR and planning template designs because they're fragmented, they're problem focused, they're not fun to write for the practitioner, and most importantly, they're not a meaningful tool to help shape the person's recovery over time. So these are just a couple of quotes. A few years ago in the MHTTC, we did a learning collaborative on person-centered recovery planning, the 6 states of New England. And these are some quotes that came out of our learning collaborative evaluation. And you can see from the bottom one there, when we talked about both facilitators and barriers to implementation, it sounds kind of ridiculous that a form kept us from doing what we were going to do, but it did, because it was what it represented. I mean, how do I, can I just write it on a piece of notebook paper for you and hand it to you? I mean, that would be a lot easier. So people had it up here and they had the flow and they had developed the skills, but they were really struggling to activate this in their plan. Okay. So let me do another quick poll here. Go back. And I want to get a sense of how this compares with your experience. So you should see a poll there. Would you say that your EHR planning template, which of these 3 options? Go ahead and vote here for us.
I don't see a poll.
Do other folks see it? Dan, do you see it?
I don't see one.
Yeah, it's up there. It's those 3 boxes on the screen. It doesn't look, it looks a little different.
There's no poll.
Anybody else want to weigh in here? So it's the 3 boxes on the screen. If you can't see the poll, it's viewing on my end. Go ahead and put your response in the chat. Does your EHR make it easier to write a good person-centered plan? Does it have no impact on making your plans person-centered? Or does it kind of get in the way? Does it hinder your ability to write a person-centered plan? You can go ahead and put that in the chat if you can't. Here, hold on. Oh,
Yep, here they come. Yep.
oh, so some are coming into the chat.
There it is.
And do you see it? Okay. Sorry about that. I'm juggling multiple windows today. I appreciate your patience. We're actually doing good on our schedule, Dan, so I think we're in good shape.
Good. There it is.
All right, we'll give it just another minute here. What's a general consensus in the chat, Dan? Can you?
It's kind of what you're seeing on the screen.
On the screen. Okay. All right.
Which is it's kind of split, mostly hinder, to
Yeah.
no impact, and we do have one person who says that it makes it
easier. Good. All right. Well, there's some progress being made out there. But in general, your experience fits with what we often hear around the country in our travels, is that even when you have a well-prepared workforce, they can really, really struggle to translate good person-centered thinking into an EHR design that does not follow that flow conceptually or from a values perspective. So let me just say that there's a couple of different things that we want to accomplish today, right? So for those of you who may be in the process of thinking about designing or redesigning, we want you to be able to think about some front-end considerations when you're choosing a vendor, or if you're negotiating with a current vendor, the things that you might ask for from a design perspective. We want you to walk away with some really concrete strategies for what it should look like structurally in between what Dan's going to walk you through and the sample that I share. We think that will come through very prominently. And we want you to be able to talk about and identify at least a couple of implementation strategies that support kind of the quality uptake of a newly designed EHR. And I will just end before I turn it over to Dan with a caveat on that front, because we've done a lot of work in this space, including together over the years with EHR design. And there have been organizations that I have worked with, sometimes in a multi-year process, to design something from the ground up. And we've designed something that is beautifully person-centered, that follows the flow and the logic and the way that Dan's going to tell you. And then I go back 6 months later, a year later, and somehow the staff have managed to put the same old medication compliance and clinical stability into the field, despite the fact that they've been kind of handed a really nice person-centered EHR on a platter, a silver platter. And I just think that topic is really important. And Dan's going to talk about this a little bit later, because even with the most optimally designed EHR, the quality of the plans you're going to get out of them are only as good as the quality and the skills and the values of the staff who are using them. So I can't emphasize enough how important, also thinking about workforce development so they can get the most out of the tool. It really matters. And Dan's going to talk a little bit about really all of those things. So I'm going to stop now and go on mute. I'm going to pass it over to Dan. And Dan's going to let me know. I'm going to transition his slides here for him.
Okay, thank you, Janice. Okay, so I'm going to speak mainly about an experience I had at Newport Mental Health in Newport, Rhode Island. I had the rare opportunity of working with a CEO. I was the chief clinical officer there, and who not only had the desire but insisted that the new electronic health record and actually the entire health record be recovery oriented and person centered. So a quick shout out to Jamie Lahane and Newport Mental Health for really wanting to do this. Okay, and I had actually done some design work with Janice using, before the electronic health records, using like Microsoft Access formats, But he said, do it. Okay. I will say the design process took a little more than a year. And then the rollout, took several months after that, but it's out there. It's actually up, fully operational. And as Janice said, it was one of the factors that shifted the people's practice, because what they were looking at in the screen was asking them different things than it used to. Okay. So what I want to do, I want to quickly go through some structural issues, which is, what should it look like? Okay, so if you're talking about a person-centered electronic health record, what are the key things that need to be in there or not in there? And then I want to take you through actually some of the design that we did in Newport, so you can actually see what it looks like. And mostly I'm going to focus on the plan, because that was sort of at the heart of it. But I do want to touch on a couple other aspects of the electronic health record, which are tied in and which are just as important. Okay. And then talk a little bit about QI, and very quickly on just implementation of electronic health records. I could spend days talking about that, but we don't have the time. Okay. So what's different? What makes first of all, a plan in general, but an electronic template different? So the main thing, I would say, if there's one thing, okay, your traditional structure, and this is actually hardwired into most electronic health records, starts with the problem at the top. There's a hierarchy. What's the problem? Then what's the goal to get rid of the problem or address the problem? And then you have things like measure objectives. Sometimes, if you're lucky, you'll see some strengths in there. Okay. And then the actions. What are you going to do about it? And the actions in a traditional electronic health record tend to focus only on what you or the agency are going to do and what you're going to get paid for. Okay. So the big number one change is to flip that hierarchy. What's driving this whole thing, and what literally rises to the top of the hierarchy, are that the goals are driving it and not the problems. Okay, so you'll see when we get into the structure, literally they come first and they sit at the top. Okay. And then things flow from there. The problem, which used to be drive it, becomes barriers that are in the way of reaching the goal. So that's the big conceptual shift here. Okay. And I'm going to show you sort of what that looks like when you actually build it in. Okay. All right. Principle number 2. We believe a person-centered process is a dialogue between the practitioners and the person whose plan it is. So sometimes you will see, person-centered, I'm just going to write down what you have to say, I'm just your scribe. That's not what this is about. A person-centered process is an interaction and a collaboration between the helping professionals and the person in recovery. You need a place to reflect that. You need language that reflects that. Okay. And you need a way to, what are you going to do when you don't agree? Okay. We, I think, successfully integrated the idea that how do you overcome these barriers? So the old problems become barriers. So how do you get past those barriers? Well, one of the things you're going to need is your strengths. Okay. And you'll see where and how we built it in. So often you will see strengths kind of on the side, somewhere in the assessments. We felt they needed to be more alive which is how are the strengths actually used to overcome the barriers. And the last piece here is just, it matters what comes first. So when I looked at our old plan, the first thing you see is the diagnosis, okay? Which is really important and is required by virtually every funder everywhere. That somewhere in your document, you need to reflect the diagnosis. It doesn't have to be the first thing you see. Okay. The other assumption built on this is whatever you do, the person's going to see it, they're going to have it, they're going to get a copy of it. So you're not talking about somebody, you're talking with them. So you have to assume a full transparency here. Okay, there's something in the chat there, Jen. I don't know if you see it.
That's okay. It's just somebody came a little late. That's all right. No worries.
Got it. Okay. So, all right. So this is some of what I was just describing before. Okay. So in your in the typical medically driven plan, it starts with the problem. And I should say, the last I checked, versus virtually every plan off the shelf still looks this way. Okay, Jen, you've been out there more than me, so it's still pretty hard to find the restructured plan. Okay, but it's typically like this. You list your problems: assaultive behavior, poor hygiene, substance use, hallucinations, and then your plan sort of goes from there to address these things. Versus the core here is, what do you want? What do you need? What is important to you? I want my job back so I can provide for my kids. Okay. So how are we going to get there? Okay. And what's in the way? Okay. So again, one of the reasons we did this, and this comes both from my clinical and administrative experience, people will engage around this versus you listing out everything that's wrong with them. Okay. So again, you'll see here the sort of the list of things that are still to be worked on, but they have a different context. Jen, slide. Okay, I'm quickly just, you probably can't even see this that well. This is the old format. And again, it goes down, typically starts with the problem, followed by the goal, then the short-term goal or the measurable objectives, and then the interventions. Okay, this is your classic treatment plan structure. Okay, and you'll also notice there's a lot of problems. Okay, and we're going to talk about this whole idea of domains and do you need all of these things? Because I don't know about you, but I would have a hard time working on all of these things. Okay, next.
So this is what we're moving away from.
Yes, in case you didn't get that. And I'm just briefly going to stay here because this is actually becomes the printout from what I'm going to show you from the screens. But again, what is it? The first thing you see, is the goal. Okay. And again, I'm just let you look at it for a minute. We're going to break this down as we actually get into the screens.
Yep. And we're going to end with an example later.
Yep. Okay. So here's another biggie. Okay. So one of the advantages of electronic health record is you can have drop downs, you can auto text, you can make it fast and easy. It does a lot of things. It makes it faster, makes it easier on your staff. You eliminate error, okay? And sometimes if you have things, that are required for your billing, make sure, you make sure they're in there. Required fields are like that. But the drop downs are there. They are problematic for a person-centered plan. So like I said, I'm still a practicing clinician. So I see one of these, one half of me is great. I can just breathe through this baby and knock it right out fast, give me the next one. But then if I go into the chart to actually read about the person, I don't know anything about them because it doesn't tell you anything, and it doesn't tell you who they are and what's important to them. So you will see when we get to the example, there are, we went with kind of a hybrid. I would say it's 85% open text, but those things that had to be there, we did use drop downs. Okay. But the majority of the plan is open text, so you can actually individualize it and write about that person that you're with, not, you know, just pulling it from a menu. Okay. Let's see, did I get everything there? Yeah, let's go to the next one because I'm going
And
to
I'll
talk.
just add, as we transition, just having worked with you in that process, there is a way to capitalize on the technical efficiencies and some aspects, like Dan said, that really lend themselves nicely to those drop downs, especially around your interventions. Who's doing it? When are they doing it? You know, what are they doing exactly? But then there's certain aspects of it that obviously have to be individualized, especially that goal statement. The last piece here, the bullet here, in terms of auto-populating libraries, what Dan is talking about, what we're introducing, is obviously very different. And you know, when you have sort of models that start with, this is a diagnosis, the following 10 symptoms and functional impairments are associated with a diagnosis. So pick your diagnosis, pick the primary functional impairments that are associated with it. Once you've picked the impairment, then pick from the drop-down of an auto-generated, populated short-term objective that meets your SMART criteria. And then we can match our protocol-driven interventions. And those kinds of models have no place in creating a good person-centered plan. We are absolutely cognizant of the need to promote efficiency and to make use of the technology, but there has to be some kind of a hybrid that makes sure that in maximizing the efficiency, we're not losing the person, right?
Yep.
Oops, let me click down here for you.
Yep. Which is this, what Janice just said. It just, it doesn't work. Okay. And again, for all the efficiency and the time saving, it just, we're generally, we're pretty, we don't usually tell people do or don't do something. This is one. It's just, they just don't work in a real person-centered recovery plan.
Sorry, Dan, I stole your thunder. I forgot that we had a segue to a whole slide.
Oh, no.
It's that important to us.
Beautifully.
All right, now I'll get you to the next one.
Okay. So here's another one. The idea of domains. Okay. So if you noticed on the bad or the old treatment plan, there are a lot of, there's domains. There's symptoms, there's drug and alcohol, they typically they match with life domains. So we've kind of gotten to the point where we've gotten away from domains for a couple of reasons. Okay. One is they actually, when you have them, people feel the obligation to fill them all up, and you end up with plans with 8 goals, and it's just not manageable for anybody to actually do. The other thing is there tends to be a lot of redundancy in what you're going to do might address several goals. Okay. So if you have a goal to get back to work and to increase visitation with your family, there might be a number of goals that have the same activity. Okay. If somebody's going to go into therapy and work on certain things, that activity is actually going to apply to several goals. So we think a couple really tight, well-written goals are better than sort of forcing people into domains. I will say I do support domains in the assessment section because it reminds people to cover things. Okay, and we're going to quickly look at that at the end here. So again, so it allows you to put multiple things under one overarching goals, and some of that diversification can take place in the short-term objectives and the activities. Okay. Okay. That's okay. And well, and Janice mentioned this before. You can set up the most beautiful template in the world, and it doesn't guarantee what people are going to put into it. So again, this is not a substitute for critical thinking, supervision, and training. Okay. Okay, so there's some other things that we wanted to make sure were in there. So again, typically in a treatment plan, you're just talking about what you as the professionals are going to do. Okay. But in recovery, there's a lot more people than the professionals involved in realizing somebody's recovery. First and foremost, them, the person whose plan it is. And then also all the natural supports. Okay, so again, what's the value of a template? You can prompt people to make sure they're including and thinking about things. So there you will see specific prompts and specific areas on the self-directed actions by the individual. Okay. And then also for their natural support systems. I'll talk about it. Gets a little tricky, but I'll save that for like where you put it. Okay. The other thing is if something is a staff's view, it is clearly designated as stuff and not just listed as the reality. Okay. So we are trying to represent primarily the person's view about what they're going to do and what they want to do, and have the staff views integrated in, but a staff view is very clearly designated that this is the staff perspective, and you'll see how we did that. Okay. Okay. All right. Next. I was looking to advance the slide and realizing I can't do that. Okay, so again, you'll see the self-directed actions and natural supports. And Janice has some great examples here. Okay, Frank will attend an AA meeting a minimum of 3 times per week. So just to give you a little preview, that sounds a lot about like a measurable objective. So the question about where to put it, we'll talk about to sort of avoid some of those redundancies. Wayne will call the phone company within 1 week and get a copy of his bill so he can work towards paying it off. All right. So it's just not about what happens in the treatment. It's what the person's going to do. And then the natural supports. Again, recovery is all, people don't live in your office. They live in a world, and the people in the world are absolutely critical to recovery. So we wanted to emphasize and have a place to put that. So within 1 week, Father Cronin, Hilda's priest, will arrange rides to and from Sunday services. Within 4 weeks, Shirley's sister will help Shirley get a disability pass, reduce fare on public transportation. So again, I'm getting a little ahead of myself, but like the strengths, the idea was not just to list who the natural supports are, but what are they actually going to do? Okay. And how does what they are going to do support the person's goal? Okay, next. Just another quick, so you are going to notice when we get in prompts. Okay. So you'll see these here. So they're built they're built-in learning tools every time somebody looks at the screen. You know, so what is a recovery goal? Okay. What are strengths and resources? And I'm going to talk all about each of these more when we actually get into the actual plan. But what you prompt, particularly if you have an open text field, people can write anything, and it's, you're not dictating it by a drop down. This is where you help to guide them. Okay, next. Okay, and these are some more prompts. Each of these prompts actually correspond to a section of the plan, which you'll see in a minute. Okay. Okay, so let's go ahead, because I'll show them in the plan. Okay, so this is actually when someone goes in to write a plan. This is the first screen. This is an actual screenshot from the Newport Mental Health Plan. Okay, so a few things here. Aside from the, what period are you covering, and the things you have to put into every plan. The integrated summary. So the integrated summary is the transition from the assessment to the plan, right? Okay, and again, we're not going to get into. Janice does a wonderful training on integrated summaries and how they should just take you right to the plan. We had some debate. Does it go in the assessment? Does it go in the plan? We decided to put it right here so people are looking at it as they're setting the goals. Okay. Next thing on the goals. Okay. So you'll see on the side, there's 1, 2, 3, 4, 5. You can have as many of these as you want. Okay. Again, you have to train to how many you think is ideal, and work with the person on that. And it's, as you see, it's an open text box. Okay. Just from one quick structure note, what I'm showing you now goes across the entire plan. So when we dive down a little more in each of these goals, if I clicked on that goal there, it's going to take you in, and then you see the hierarchy for each goal. Okay, so one other thing here, just I want to mention. So one of the things that came up when we're doing a person-centered plan, something might have come up during the assessment that seemed important, raised some alarms, might pose some risk, but the person has other priorities. That is not what they want to work on right then. Okay, so you don't want people to think you just forgot it. Okay, this came up on our accreditation. By the way, the Joint Commission loved this format. But it would be raised. Oh, I read remember, tracers, for those of you that do that. You raise this issue during the assessment, but I don't see anything about it in the plan. Why not? So this is where you put down that, no, we did not forget it, but the person said their priority of working on what they're going to work on right now is this. So that's not why it's specifically addressed in the plan. Okay. And I will mention some of this stuff came up over time. We didn't think of that one right in the beginning. But it quickly emerged. Okay, next slide. And these were just some other things that are upfront and not goal specific. I will mention the personal wellness strategies. Okay, so this was the one, where we said on the slide, it's really important to identify what the person themselves is going to be doing working on their plan. We found that a lot of what we listed there actually were the measurable objectives. So it got really redundant to list that in each goal and then have measurable objectives, which tended to be the same thing. So what we did is said, okay, we're going to put a lot of those specifics right into the objectives, but we need just a place to generally talk about wellness strategies that people apply kind of across the board. And this was the place for that. And this actually, people really use this a lot. This is just where, I have a general strategy of journaling, just helps me to feel on top of things. Okay.
And Dan, I'll just add, because I've seen a lot of these plans and I hear a challenge in my travels. So often practitioners work really hard in that strengths-based inventory, profiling, interview process, and they have this beautiful, rich set of strengths available. But then you look through the plan documentation, the goals, the short-term objectives, the interventions, and they're nowhere to be found. It's such a missed opportunity. And when people are struggling like that, this dedicated field is the place where we will tell people, if you've gotten through your entire plan development and you haven't concretely tapped into those strengths, this is the easiest and most efficient place to do it in your structure. And like Dan's saying, people use it really consistently and in a really meaningful way for the person to identify their personal strengths that they can use as those daily wellness strategies.
Yep. So the next, actually go back for 1 second.
Oh, sorry.
I just want to
There
speak.
you go.
Yeah, thank you. The next 3 fields I want to mention, because these are requirements. Okay, so remember, as you're building you still have to meet all of your licensing and funding requirements. So one of the requirements in Rhode Island was you have to identify your discharge criteria. Okay, and you have to list your diagnosis on the plan. Again, it's there. It is not the first thing you're going to see. And also you documenting the person's participation. Now, we would often say it's pretty obvious that somebody participated here because it's entirely in their words and all, but there are situations where somebody's unavailable or does not want to participate, and this is just a place to document that. Okay. Next. There we go. Okay. So what you see here is within each goal. So when you, on that first screen, if you write out your goal and you click on it, it's going to take you here. The first field is just a restatement. You don't have to put it in again. It brings forward the goal that you wrote on the other screen. Okay. And then we sort of go down. This is sort of in the meat of the plan here. Okay, so a couple things. Remember, we talked about that this is a place that reflects the collaboration between the person in recovery and the staff. Okay, this is that place. So the whole thing is meant to be in the words and the language of the person, reflect their views. But there are times, and you'll notice it starts with if needed, when necessary, where the staff really feels they either do not agree, okay, or that there's some elaboration is needed. And this is where we put that in. And as we said earlier, it's clearly says whose word it is. It's not just fact per se, but it is the views of the clinician. And this really helped our clinicians to feel more comfortable about the plans. Okay. It's like, I don't always agree. And this is one, we call this the agree to disagree field. Okay. But there's a place to put that in. Okay. Next, the strengths and the resources. So as Janice was saying, ideally, strengths and resources are not something that is listed off to the side. They are put in as things that are used to attain the goals and overcome the barriers. barriers. Okay, and we stick it right in there. Every goal's got one. Okay, so you may use different strengths to attain different goals. Okay, so if it's a work-related goal, it might have to do with your skills. If it's a family-related goal, it might call on different relationships. So there may be different strengths that you're going to bring to the table to try to get to your goal. The next one is barriers, and you'll see that. So we broke this into two parts, and you'll see the second part on the next screen. So the barriers is the old problems, right? This is things in the way. This is where your medical necessity gets justified. The things that are in the way of getting to the goal. I want to go back to work. I have a really hard time concentrating. I end up getting nervous and walking out of my jobs. Okay. This is the stuff you're going to be working on to get to the goal. When we first put this in as one field, we tended just to get, I don't have money for the bus, a lot of environmentally focused barriers. So we broke it out into two parts, because you do need this in here to justify the work that the agency is doing that you're going to get paid for. Okay, so if you read the prompt, the problems, needs, functional impairments, skills deficits from the assessment that interfere with the goal attainment, with particular focus on those needs directly related to mental health or addiction issues. Okay. Again, we got pretty directive here with the prompts because you really need to have some of that things in there, again, from the whole medical necessity point of view, and to support your billing. But it also drives a lot of what the activities are going to be. Okay. Next screen, please. Okay, and here's the second half of that. That doesn't mean you don't have environmental barriers that need to be dealt with. If somebody doesn't have money to take the bus to go to work, they're not going to be able to go to work. Okay, and your plan is going to include things that are going to try to address those things. But again, we thought it was really important to break that out. Okay. Okay. So the next thing you have are the measurable objectives. Okay. And this is where some of the part of the hybrid came in. Okay. We need a start date, an end date. Okay. And this has what they call the one-to-many relationship. You can have as many objectives for each goal as you want. So you could keep adding them, and every time you put one in, it adds a line to the table. Okay. But remember we said hybrid. Okay. You still got to describe what it is. Okay. So when you add these, okay, which barrier from the assessment are you addressing in this objective? Again, we're trying to sort of tie it back. And we put in the as evidenced by, which is because we found the hardest part for people to really do smart objectives, concretely measurable objectives. This is where they put them in. Okay. Again, Janice teaches a lot that the objectives are not just going to therapy and all, that they're actually benchmarks of attainment along the way. And again, that's where we found some of the overlap in what the person's going to do. So if you want a job, well, I'm gonna go through, I'm gonna go on Indeed twice a week. I'm gonna look at, I almost said the want ads, but I was gonna date myself here. But and the person is doing certain activities, and if they're doing that, they're working towards the attainment of their goal, their global long-term goal. Okay. And then the next part is the services that you are going to provide, that your agency, your provider is going to provide. And you'll see this one is all mostly all drop downs, because you need this, like what discipline, how often, the duration, which objectives are addressed. You guys probably should recognize this. That's a pretty standard format in services provided, with for each one. So every time you add a line to that table, you get the text box on the right. Well, what specifically are you actually going to do? So, typically this is at the layer. Okay, so I'm a psychologist. I'm going to provide weekly psychotherapy for 3 months. Okay. In the box, you talk about, well, we are going to work on desensitizing to the anxiety around taking the bus to going to work, because that's a barrier for this person to get back to work. Okay. That's the hybrid right there. Next.
And that's the piece, that last part that Dan said, the who, the what you're doing, when, on what schedule. You can get that into your drop downs, but that last part is the why, right? What's the individualized purpose and intent of that intervention? And Dan just gave you a really nice example of that. And that's the piece that is most often missing. And that's the piece that's really necessary to create that person-centered plan.
Okay. So remember, we said it's not just about what you as the providers are doing. Okay. And we put a specific place to show the natural supports, the community supports. It was a little different. You don't have the same requirement of the duration and all. So we wanted to know who was going to do it. Something about what type of support. So that's a drop down as well. But again, what's the nature of it? Joe's sister, when Joe gets nervous at work, he will be able to call his sister to kind of bounce off ideas of what's happening there. Okay. Again, it's not just that they exist, but they have an active part in the plan. Okay. Okay. So that's it, basically. And again, you can have as many of those goals as you want. We tended to train to, 2, max 3 really well-written goals, sort of integrated goals. When you start to get beyond that, it seems to be more than people were able to do at any given time. I know for me that would be true. Okay. Just a few things beyond the plan itself. Okay. So how do other documents in your EHR reflect the principles of person-centered recovery planning, or even more generally, just a recovery-oriented system of care? So language, again, the whole drop-down thing versus open text. How do they logically relate? So one I'm going to spend a little time on is the assessment, because I think it's just so critical and often will drive the plan. So the questions you ask, if you're not asking the right questions in the assessment, you're not going to be positioned to really launch the plan. Okay. Anyway, just before I go to that, there are opportunities on how you word it and what you ask to promote patient activation and illness self-management. There are abilities to pull in other documents like advanced directives, crisis management plans. This has really advanced, the next one, since I've been in there, the whole idea of patient portals, okay, where a person can actually get into the actual electronic health record or parts of it and make their own direct inputs and contributions. That's a booming area, this. And how changeable over time is things. Okay. next one. Okay, so let me just spend a minute on the assessment. And so we created a worksheet, which was essentially an assessment to gather the information that was really important. And this one was domain driven. Okay, again, because we thought, let's just at least ask. Somebody may just say, that's not relevant for me, and that's fine, and then you just move on. But the basic idea was, where are you now? You have goals. You want to change anything about that? What's in the way? Again, if the staff needs to weigh in, and we ask, is that something you want to work on now? Yeah, or maybe later, or that's not one for me. Okay, so you'll just see again some of the language. Who are the people that are important in your life? Okay, who do you turn to? How are your friendships going? How are your family? Do you have an intimate relationship? You're trying to get a sense of what the important relationships are for that person. And as you do that, is there anything you want to change here? And that I can't do. When I did this way back in Connecticut, and I remember when we rolled this out, somebody said, nobody ever asked me that. And people were just so grateful to be asked in a way about what was important to them. Anyway, next.
I'm going to give you like
again, sort of
about 7 minutes, Dan. Can you do that? I want to make sure we have time for the sample at the end. And quick note to the audience, if you have questions, put them in the chat box, so that'll help us figure out how much time we have to get through material.
Yep.
All right, there you go.
On it. Okay, let's go into the next gear. All right. So again, this is just who are the important people, and who do you want to be part of your recovery team? Next. I could spend days talking about workflow, but I just want to mention it. It's when you're getting your plan, your record, you just go through it. Okay, so here's one. This is just a simple, okay, what's my workflow? We do an initial assessment, and from that assessment, we do the initial plan. Okay, over the next period, you're providing treatment. There's all these activities, which are usually reflected in your progress notes, maybe other documents. You come up to the reassessment of what's happened, and you revise your plan, and you do a new plan. And that cycle kind of keeps repeating itself. I can't tell you how many places forget to deal with the updating of the plan and the new plan. And I'll tell you, just from a logical point of view and the complexity of the plan, the hardest part was actually getting the recovery plan review. So do I bring stuff forward? Do I make them start from scratch here? Okay, what comes forward? If I bring everything forward, somebody's just going to have the same plan for the rest of their life. Okay, and it just really do your workflows out, and let that should be what be driving a lot of your design, not the form driving the workflow, which is more often how it happens. Okay, all right, next. Okay, quality. Okay, and I'm just going to speak really quickly to quality. Again, you can have the best design in the world, and people will still, if they are not trained and they are not supervised, if they don't understand and buy into the concepts of recovery and person-centered care, you're still going to see the same old stuff in the new boxes. Okay, so here's some strategies about quality. Okay, and again, there's a whole corporate, agency culture that goes in here. It's not a gotcha thing, so all along, you want to be working with your staff, that this is collaborative. You want to build their skills. And you can't just do, smash them for not getting it. This is complex. These are complex skills. It takes time, and you have to be in it for the long haul to bring people up to speed and have a way to bring new people up to speed. Okay. So how do you do just a few kind of things of using the actual record? So we have an explanation of what each of these fields in there is and what we're looking for, because people, they don't know. Okay. And, ideally, it's nice to actually have a nice sample right online. So people can pop up, what's a good goal look like? And you call up the example, it's right there, and then people can use that. Okay, next. We have a tool, there are a number of tools out there that basically take that last form about what you're looking for and turn it into a rating form, and a QI measure. Again, this is not meant to be a punitive thing, but it's meant to be a supervision tool, and a tool that tells you. So on an individual level, you can look at what supervision needs to do, but you may also find on an agency level, we found people struggling with really writing good measurable objectives. So if you see it across the board, this is a training issue. Okay. Next. Okay. Again, I made this sound like a smooth process. It was not. But there were just a few hints, just generally on design. No matter what you do, it's going to change, and you want to know of what's it going to take to actually change something. How much can you do as the end user, and how much has to go back to the vendor? And if it does have to go back to the vendor, how responsive are they going to be to make your changes? Talk to their customers before you select them, and not just the ones they give you. But, and it's always, I will add, make sure you're early on, you're talking to the developers and not just the salespeople, because I can tell you how many times the developer said, we could do that. We can't do that. Okay. So again, you want multiple access for multiple users. It's a multidisciplinary process. What are the links between the other parts of the plan? Think what carries forward. Can you define that? Like we said, we're really big on the hybrid with the bias towards more open text. And is there, again, what are the interfaces between different parts of the plan? Next. Yeah, there's another one. Okay, so like I said, it took us a year to do this, and I would say we were really good about involving our end users along. We had a very active and large work group of representatives from different parts of the agency. So by the time it came around, there were parts that people didn't like, but there was pretty wide buy-in because they had worked to help define it. Make sure they give you a good test environment. It all looks nice until you try to do it. Again, plot out your workflows and try to follow your workflows. If they get stuck, the earlier you find that all out before things are, hardwired in, the better. We found that, so if you're implementing both person-centered care and a new EHR, you need training in both. Okay. Okay. And we worked with Janice, who did a lot of we timed the content training with the rollout of the EHR, but not exactly, because you also have to learn what to click, and how to get around. Okay. So that's the timing. Again, it takes a lot to go live. Again, I'm not going to go in it to today. Find the documentation requirements is related to transition. Oh, okay. I said, what the heck was I thinking? So at this point, most of you have an electronic health record. So if you're going from an old one to a new one, that whole what data comes over and what am I starting fresh? So for our recovery plans, we couldn't bring forward any of the old plans. They just didn't fit. They didn't work. Okay. So how do you deal with that transition? So we made a decision that as somebody comes due for their plan, they're going to get the new one, and they would have the old one live until that time. So we didn't bombard people with the requirements of doing, hundreds of plans in a short period of time. But it's those kind of transition issues you need to think about as well. Okay. Okay.
Maybe you did it. I gave you an impossible task and you did it. I'm going to end, as I had said, with an actual sample, just to tell you a sense of what it might look like, give you a couple resources. Dan will keep an eye on a chat if we have any questions come in. But we can't emphasize enough the importance of creating samples really as training tools and creating samples that actually live inside the design and template of your EHR, because that reinforces both the quality in the person-centered planning itself and the documentation, but also the technical savvy of the what goes where, so that the logic stays tight. We also say that it's helpful to show people a prototype of what it should look like, and also what it should not look like. So sometimes we'll give people those traditional plans so they can have more of a sense of urgency around changing some of this documentation. So let me introduce you to Mr. Blake, who you can read about up here. He's a 33-year-old African-American man. He's in a shared apartment program. He has spent a lot of time over the years in the state hospital, lots of time unhoused, but he's enjoying his single longest period of living in the community in this shared apartment. He does eventually want to get to his own apartment where he'd have more control over his life and his independence. He's got lots of strengths to draw upon. A cousin who is very active and on the scene. He's very persistent with follow through. He got his GED despite a lot of the struggles he was going through, and he's a really strong self-advocate for himself. He is living with a diagnosis of schizophrenia. He can often feel really distressed by his mental health issues. He's really pretty isolated at the time of this plan development, very rarely leaving his apartment other than to go to mental health appointments. He's very uncomfortable around other people, often thinks they're out to harm him in some way, and he can feel threatened. And while he's had that experience for quite a while, it was intensified by the traumatic passing of a son who died in a young age of SIDS, of sudden infant death syndrome. And he developed the belief that the son had been murdered, and did not believe that it was SIDS. And then that further really impacted his distrust of others who didn't believe him, including his mom, who he had been very close to. She's very supportive. But there's a lot of stress in that relationship because she didn't share his belief around the passing of his son. And so at the time of this plan development, he really feels super isolated. And he wants to have better relationships with people, and he wants to feel more comfortable with people. So when you think about what a traditional plan for Mr. Blake might look like, it would pretty quickly resort to goal number 1, medication compliance, goal number 2, clinical stability, goal number 3, increase insight into your paranoid delusions, and really slip into a power struggle around that. But with this model, we have an opportunity to do something that looks really different. So let me show you what it looked like in this hybrid model that Dan was sharing. So the font is small, but I checked to make sure that you can read it there. You see right at the top, I don't want to be alone anymore. I want to have friends and family in my life. That is his goal, what is most important to him, okay? Then he has a short-term goal, a short-term SMART goal. Well, right now he's super isolated, right? Because he's feeling so uncomfortable around people. So what does that short-term goal look like? Well, maybe he's going to participate in a minimum of 2 preferred social activities each week outside his apartment over the next 3 months, as evidenced by the report of the residential counselor. So you got to start somewhere, just kind of getting out and about, okay? Then what kinds of individualized services and supports does he need? Maybe he's going to have some trauma-informed individual therapy from a clinician on a certain schedule, just for the purpose of helping him really process the loss and the trauma around the death of his son. Again, to sort of help him move forward and be more comfortable with others. You know, maybe he's going to have a community integration coordinator who's going to do a community connections group for him to help him identify and access some of these social and recreational outings that fit with his preferences and also his wallet, his resources. Then maybe you've got a peer coordinator who's helping him create a RAP plan, a wellness recovery action plan that's helping him with those daily wellness strategies that he can use when he's feeling really distressed, particularly as he sort of increases in social situations. And then you've got some family therapy that might target some of the strain in his relationships with his mother so they can better understand each other's perspectives. So that top set is really your professional, clinical, rehabilitative, peer-based services. But then what you start to see down the bottom is you have an action step for Mr. Blake in terms of reaching out to his mom in order to get her engaged in this family-based therapy with the clinician. And then the bottom natural support action, remember that cousin that was a real support to him, getting that cousin involved with him. Maybe he agrees to go to the monthly potluck dinners in the housing complex, just so that Mr. Blake doesn't have to go alone. And he has an opportunity to meet new people and really just practice different sort of coping and social skills that he's been working on. And he doesn't have to do it alone. He's got a natural supporter there with him. Maybe over time he works towards independence. But hopefully you can see by us ending here how you've got that hybrid EHR design. It allows you to start at the very top, stay true to the goal that is most important to the person, but yet you are still hitting all of the required elements in your plan documentation. So let me just, we have about 6 minutes left. Parting resources we're going to give you, and then we'll see if we have any questions coming in. When you get the slides and materials, these will all be linked. But I didn't mention that everything that we've talked about in the webinar today, Dan and I, along with a few colleagues, we actually published an article on this very topic, kind of walking through the design issues, called The Promise and Pitfalls of Electronic Health Records and Person-Centered Care Planning, right? Again, how they can make or break the quality of this. So I put a link to the article in there. There's some nice resources around staff-based competencies in person-centered planning from NCAPS is on the top right. The SAMHSA issue brief for organizational leaders, including state mental health authority leadership, is on the bottom left. And on the bottom right, from a more of a clinical workforce development perspective, there's a set of tools that are available to you called our Recovery Roadmap Tips tools, which really kind of walk you through the basics of what does a good person-centered planning meeting and conversation look like? And then importantly, what are some of the indicators of what a good person-centered recovery plan looks like? And we've gotten a lot of good feedback on them over the years because they've got a lot of practical tips and tools and examples. And I'm going to pause here at this is our QR code for our evaluation link. We actually saved 5 minutes. I responded to a few things in the chat as we went, but you can feel free at this point to unmute, to ask us if you'd like to hear more about any particular topic. Got a couple minutes, we know we were on a speed dating version, going very fast through some topics.
Janice, someone was asking if we can share the links
So the links will all be in the slides, and you will get, as a follow-up within usually about a week or so, you'll get a full copy of the slides that have live links. Yep. There was a comment that came into the chat earlier that was important. It related to what Dan was talking about, workflow, and the importance of thinking about your workflows from assessment to initial plan to ongoing plan to progress notes. And the comment that had come into the chat also, and we've seen this happen, is that sometimes who is doing what when really matters, because that's not often one continuous person. So the challenge was raised about sometimes you have an assessment and an initial plan being done by one person, and then it gets passed off to sort of a continuing treatment team. Sometimes the person who's picking up a plan may not have even met with the individual yet, right? And doesn't have the relationship with them. So those are all things that you have to think about in your workflows. What does the transition from one practitioner to the next look like? So that was, I think, an important observation. What else? Anything? We'll definitely get you the links.
Yep.
You can also unmute if there's anything. I would say also, maybe just by way of parting, and we'll give you 2 minutes back, that Dan and I are very open to email correspondence. I don't actually think, Dan, you want to put yours in the chat box now if people wanted to reach out to you. I will do the same, because if there is something, or as you go back and you resonate kind of on what we've shared today, if you have specific questions as it relates to your own process at your own organization, we're typically very good about getting back to folks and happy to share more information. All right. Well, I think anything, Dan, that you want to say by?
No, again, we covered a lot quickly. Again, I emphasize what Janet just said, would certainly be helpful, glad to help follow up if people have questions. It's a complicated thing, but the payoff can really be immense if you can even move the dial a bit towards
Really
something
does.
that's more
Yeah,
personal.
did you put your email in the chat
Yeah,
box?
it's there.
Okay, good. I didn't. Oh, there you go. Now.
So I just sent it to Glenn. Okay.
Oh, so if you want to get in touch with Dan, he's going to put his email to everyone in the chat box. So we'll give you a second for that.
Okay.
But thank you again for signing on and joining us. The other thing, within a week, recording of this, if you'd like to share it with any colleagues at your organization, please feel free to do that. The recording and the slides will be available, and there's Dan's email for you. So now you know where to find us both.
I have a quick question.
Sure, Alicia.
I don't know if I saw it in the slides, but is there a list of people who are already creating these systems that you would recommend?
So that's a challenging question. I think Dan said from our perspective, there probably is not a current existing off-the-shelf model that really follows the flow that we're talking about. And it really does require working with a vendor to do some customization on the front end.
We worked with Echo Vantage. They were, it took a long time, but they really did work with us to get what we wanted. So
okay, I just asked because I used to work in software development, and I found that a lot of people, when they call in and ask for customizations, often don't even know how to ask for what they need. And I think
Yeah.
that's a big challenge.
Hopefully they got some good tips today then.
Yeah, but sometimes it's speaking the developer language, like I think Dan talked about a little bit, and knowing how to bridge the gap of like what I need versus what you can do. Yeah, I
Yeah.
I did a lot of implementation interface with some of that. So
Yeah,
Yeah.
important stuff. Good. Thanks, Alicia. All right. Well, we will go ahead and give you back the rest of your day. And thanks again for joining us, and keep an eye out for the posting and the recording. Take care, everyone.
Thank you, everybody.
Thank you, Dan. We'll talk soon. Thank you,
Okay.
Glenn.
Thanks, Glenn.